The following podcast is part of a certified educational activity titled Staying on Target Against Moderate to Severe Psoriasis, Strategies for Achieving Sustained Benefits Through TYK2 Inhibition. Access the entire activity and complete the post-test at peerview.com/RJG860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. April Armstrong. I am Professor and Chief of Dermatology at UCLA. I am very excited to talk to you today about staying on target and discussing some of the treatments for achieving sustained benefits through TYK2 inhibition in patients with moderate to severe plaque psoriasis. Thank you so much for joining me today. We have 3 goals today. First, we're going to talk about the underlying pathophysiology involved in the development of plaque psoriasis, and especially focusing on IL-23 signaling and the selective targeting of TYK2 kinase inhibitors. Number 2, we're going to identify patients with psoriasis who could benefit from treatment involving TYK2 inhibition. And number 3, we're going to talk about designing a personalized management plan for patients with plaque psoriasis using a team-based approach, while also addressing individuals' treatment goals and preferences. And in addition, we're going to talk about some of the disparities in care and how we can help to close those gaps. And with that, we will go into our first section, which involves acknowledging current gaps in psoriasis care. When we think about patients with psoriasis that we see in our clinic every day, we understand from our patients that this is a chronic condition, and our patients suffer from skin symptoms involving itching and pain. In the United States, over 8 million Americans are affected. And what we also notice is that the prevalence among different racial ethnic groups are different. For example, among Caucasian patients, about 3.6% of individuals are affected. However, among Black patients, it's around 1.5%. Now, it is important to know that psoriasis is likely to be underdiagnosed among patients with skin of color due to some educational gaps we need in our field for our clinicians to recognize psoriasis and also distinguishing psoriasis from other types of skin conditions in the real-world practice. In addition to that, we also see that for all of our patients, when they have psoriasis affected, they can have psoriasis appear on any part of the body, from scalp to elbows, knees, torso, and also intimate areas such as genital areas. In addition, involvement on the palmar plantar area can confer a significant impact on patients' quality of life. Speaking of quality of life, let's take a look at a study that was done evaluating global psoriasis burden. And in this study, which I had the pleasure of working with my colleagues who really specialize in the area of psoriasis, we looked at a number of different countries and looked at the impact of psoriasis on patients' quality of life. And what we looked at was a few different things. Number 1 is that we looked at the differential impact of quality of life based on the severity of psoriasis. So if you take a look at the right side of this slide, what you will notice is that, for example, patients with mild psoriasis, which in this particular study was defined as 5% or less body surface area, there's a proportion of them who experience significant impact on their quality of life. And we think that this is maybe due to the involvement of special areas such as the face, the palmar plantar area, as well as genital area. Of course, as we go up in severity, you would expect greater proportion of patients reporting an extremely large impact on quality of life, which is what we see in patients with severe psoriasis here, defined as having BSA 10% or greater in this particular study. Now, knowing psoriasis can have a negative impact on quality of life, and in general, the more severe psoriasis can lead to greater impact in patients' quality of life, we were curious about globally, how do current treatments affect patients' quality of life? And so let's take a look at this. On the left-hand side, you see a proportion of patients who are on various therapies. For example, in this particular global study we did, 72% of the patients are on topical therapies, 42% on biologics, 23% on oral or injectable medications. And also, what we see is that one thing we note when we look at these various therapies and whether patients perceive improvement on the therapies, what we note is that for patients who are on biologic or oral therapies, the systemic therapies, they did have a higher likelihood of reporting better improvement on those therapies as compared to patients on topicals or not currently on the therapy. Now, I understand this is a global view of the impact of psoriasis and the impact of treatment for patients with psoriasis. However, as you can see, there are a large proportion of patients, regardless of what therapy they're currently on, that they reported, the therapy didn't seem to work so well for their psoriasis. So let's continue to look at also patient satisfaction on these therapies. So looking at a different measure, specifically looking at the patient satisfaction measure. And what you will notice is that current therapies do help. However, there is a large gap where we see still a large proportion of patients, regardless of what therapies that they are on, they report either uncertain about their satisfaction or unsatisfied. And oftentimes, the key reason for this dissatisfaction has to do with incomplete resolution of their skin symptoms. And for those who are on biologics who may also have psoriatic arthritis, for example, they also report incomplete resolution of their symptoms as one of the key factors contributing to their dissatisfaction. When we think about our patients with moderate to severe plaque psoriasis, we know that they have multiple treatment options available to them. However, what we also note is that even when they are on some of the existing therapies, many patients still experience substantial disease that can impact their quality of life. As you can see from this particular graph, while patients may be on a splattering of different therapies, there is still a significant proportion of patients who remain moderate disease severity, and some still remain severe disease severity despite of having access to treatments. So what we're noting also is that providers, clinicians, our goals may be a little bit different from that of patients. Typically, as clinicians, we can appreciate the signs of psoriasis and we want to improve patients such that they are completely clear. And I would say the complete clearance is something that our patients share as well. They also want to be completely clear. However, there are also some of the unseen effects. Sometimes we may only see 1% or 2% body surface area. However, that body surface area can contribute to a large decrement in patients' quality of life. So appreciating patient symptoms and also appreciating how these symptoms can sometimes disproportionately affect their quality of life and impacting each individual differently is important. Now, we talked about skin so far. We would be remiss if we didn't talk about some of the comorbidities that are associated with psoriasis. For example, patients with psoriasis are at increased risk for cardiovascular disease or inflammatory bowel disease or a number of different subdomains of cardiovascular disease, such as cardiovascular risk factors, such as metabolic disease, hypertension, diabetes, and so forth. Patients also suffer from mental health comorbidities, such as depression. Very importantly, about a third of the patients would naturally develop psoriatic arthritis if this is not intervened on. So when we see our patients with psoriasis, it's especially important to make sure that they are connected with healthcare professionals who can take care of other comorbidities. And with that in mind, let's dive into the next section. And in the next section, we are asking the question, are emerging perspectives on the pathophysiology of psoriasis and the classification of its disease severity influencing the development of new treatments? So what we're saying is that our new perspectives on the pathophysiology of psoriasis, does that impact how we develop therapies? And I would say the answer to that is yes. And now we're going to dive into why that's the case. So let's first take a look at the overview of pathogenesis of psoriasis and the mechanism of action of different therapies, including biologics. Here, what we see is a diagram that depicts the pathophysiology of psoriasis, and superimposed on that are the different biologics that are currently approved for plaque psoriasis. I want to mention a few things. When you look at this diagram, it is important to know where IL-23 is. IL-23 is secreted by dendritic cells, and IL-23 is critical for the differentiation of naive T cells into Th17 cells. These days, contrast to our prior understanding, we know now that Th17 cells is the principal cell type that affect psoriasis downstream. For the Th17 cells to be sustained and expanded, they need the stimulation from IL-23. So what do Th17 cells do in psoriasis? well, their population expand in psoriasis inappropriately, and also they secrete an excessive amount of IL-17, IL-22, which both then stimulate the keratinocytes to proliferate. When the keratinocytes are proliferated, that results in what we see clinically as thickened plaques, as thickened scales, and also this influences symptoms such as itching. And therefore, when we look at the different therapeutics and what they're targeting on, we're seeing, for example, therapies that target the cytokine of IL-23, therapies that target the cytokine receptor of IL-17. Now, these are biologic therapies, and they typically, for most biologics, they act extracellularly. That means they bind to cytokines extracellularly. However, for the cytokine to effect change, the cytokine needs to bind to its receptor, and then this can then induce intracellular change. So let's take a look at this. Here, what we see is a cytokine binding to the receptor, and we can think about IL-23 as an example of a key cytokine represented by this red ball. So the cytokine can bind to its receptor, and upon binding, this causes certain conformation changes in the receptor. And then you can have these Janus kinases that are associating themselves with the receptor. The Janus kinases then will phosphorylate, or putting the yellow P on certain target groups. And one of them are the STAT molecules. Once STAT molecules are phosphorylated, what happens is that they dimerize, they go to the nucleus, and then they will sit on the DNA and initiate the process of gene transcription, transcribing abundant IL-17s, for example. And this later on then can have its downstream effects. So when people looked at these signaling pathways, they asked the question, if we inhibit the kinase that's associated with the cytokines, with the cytokine receptor intracellularly, can you block the signaling in the cell? So this is kind of like the analogy that if someone is ringing the doorbell outside the house, so that's akin to the cytokine binding to the receptor. But let's say somehow your doorbell's mechanism is disconnected inside the house, that it's actually not connected to anything. So despite of the fact the cytokine can bind to the receptor, despite the fact that someone can be ringing the doorbell, you don't hear the doorbell inside the house. So this is an analogy to think about. If you can inhibit the kinase that's associated with the cytokine receptors, that will effectively block the transmission of the intracellular signal such that your STAT molecules will not be phosphorylated. So when we think about developing inhibitors to Janus kinases, what we have seen in the field are two things. Number one is that in psoriasis, for example, people have tried creating inhibitors to JAK1 and 3 in the past as oral therapies, but those actually have not gone on. We don't have actually any oral therapies approved for JAK1 or 3 inhibition for plaque psoriasis. Rather, they're focusing on a different kinase, which is TYK2. And later on, I'll describe why TYK2 is very specific for psoriasis pathogenesis and why we have, as a field, shied away from inhibiting JAK1 and 3, but rather focusing on TYK2 as a therapeutic target. So when we think about these inhibitors, we do think about TYK2 inhibition in a different category from the JAK1 inhibitors that we typically talk about, for example, in atopic dermatitis or approved for psoriatic arthritis or rheumatoid arthritis currently. And also you will notice is that the package inserts are very different for JAK1, 2, 3 inhibitors versus TYK2, in that TYK2 inhibitors do not have box warnings, whereas JAK1, 2, 3 inhibitors at the current time do have box warnings. Now, let's illustrate this with a case. So I want to show you a patient case. This is Mark, who is 42 years old, have had a long history of plaque psoriasis. This patient has tried topical steroids in the past, did not quite work for his moderate to severe plaque psoriasis, also tried topical calcineurin inhibitors. He has also tried a TNF inhibitor in the past, but then was lost to follow-up for a few years. So when the person came to see me again, the patient wanted to discuss various treatment options. So let's take a look at him, and he wanted to also consider possible oral options. So here is the patient, as you can see, with the involvement of plaque psoriasis on the arm as well as the back. In addition to this, the patient also has involvement of the leg as well. So when we take a look at this patient who has plaque psoriasis diffusely, I would say, overall, this patient would qualify as someone who has moderate to severe psoriasis, maybe on the moderate end of the moderate to severe plaque psoriasis. So when we examine Mark, what we notice is that the patient has BSA of 11%, has moderate disease severity, and also a DLQI score of 12. Importantly, the patient also had involvement of the scalp, and the initial laboratory workup was negative for interferon gamma release assay. Patient also did not have any risk factors for tuberculosis. The liver function enzyme is negative, and hepatitis B and C serologies were negative. So this is Mark's initial presentation back to clinic after having had a hiatus, lost to follow-up for a while. So let's talk about some of the challenges of categorizing Mark's disease severity. As you can see, we used a few different measures in dermatology for trying to capture disease severity. And when we're looking at the disease severity, the model has really changed over time. In the past, we used only body surface area as a way of measuring disease severity. And typically, for example, for the National Psoriasis Foundation's guideline that was published about a decade ago, it's looking at less than 3% being mild, 3 to 10% being moderate, and 10% being severe. However, as we know, many of us who practice know that when we're trying to get coverage for patients, insurance companies oftentimes require 10% or greater body surface area for a patient to be considered moderate to severe, to have the patient be covered for a systemic medication. And this is because in clinical trials, typically the inclusion criteria for patients getting into clinical trials is 10% or greater and PG of 3 or greater. And that is the reason oftentimes why many payers use that cutoff for moderate to severe. Now, however, there have been newer efforts in the recent years, especially this one by the International Psoriasis Council, looking at reclassification of disease severity into patients who are suitable for topical therapies and patients who should be considered for systemic therapy. And they considered that a patient should be considered for systemic therapy if you meet at least one of the following criteria. Number 1, if their body surface area is greater than 10%, or number 2, if the disease involving a special area, such as the scalp, palmar-plantar disease, genital, for example, and the face. And our patient, Mark, has scalp disease. I would say Mark also qualified for the BSA criteria too. And number 3 is that failure to topical therapy. I think this one is a little bit more controversial when you have patients who may have very limited extent psoriasis, but they do not respond optimally to topical therapy and their disease isn't in a highly sensitive area. Regardless, these are the recommendations that's set forth for considering patients for systemic therapy by the IPC. Now, I think when we evaluate our patient, the key message for this is really thinking about how do we think beyond just body surface area? And does the patient have a special area that's involved? Has the patient failed topical therapies? Now, I do recognize what is defined here as a patient who is a good candidate for systemic therapy may be different from what the payers will acknowledge. But I do think the whole field is moving towards recognizing other domains that are important for assessing disease severity that's beyond body surface area. Okay, with that, let's move on to thinking about the overall view of the JAK-STAT signaling pathway. So what's happening inside the house, right? So what's happening intracellularly, and how do we talk about the different types of Janus kinases? So here, as you can see, it will seem a little overwhelming. We have a diagram just for reference of the various different cytokines and also the different kinases intracellularly that are important for mediating these different cytokines. For example, if we take a look at the TYK2 JAK2 pairing, TYK2 JAK2 is very important for transmitting the signal of IL-23 and IL-12. And while we look at this, emphasize this is because this is key to the psoriasis pathogenesis. And through the TYK2 JAK2 pairing, what we see is that differentiation of Th1 cells, Th17 cell, sustainability of Th17 cells is also mediated through this, and expansion of Th17 cells, interferon gamma secretion, for example. We also see, if you look at the second set of the depiction here, we see type 1 interferon also signal through TYK2. And here, the type 1 interferon signals through TYK2 JAK1 pairing. And type 1 interferons include interferon alpha and interferon beta. And this particular pathway is important for a number of downstream effects, including dendritic cell maturation, B cell differentiation, T cell survival, and so forth. And the rest of the diagram is a depiction of the other pathways that are involved with JAK1, 2, 3 signaling. I do want to bring your attention to the very end of this, which shows JAK2 pairing. And this is important for hematopoiesis, for example, so for the formation of our blood cells. When we target things for psoriasis in the psoriasis pathogenesis pathway, we actually want to avoid also having some spillover effects into JAK2 inhibition. This is because if you have that, then you can potentially affect the cell lines, and you can see that in potentially laboratory perturbations when patients are on therapies that also hit the JAK2 pathway. Okay, so let's take a look at these intracellular molecules that are so important for transmitting signals. So the Janus kinase family consists of a number of different family members. The ones that are key and relevant to our discussion include TYK2, and there are other members such as JAK1, 2, and 3. So each molecule has two domains. It has an active domain, which is depicted by the blue symbol here, and then they have a regulatory domain. So you can think of active domain is where a domain that the homology, there's quite a lot of homology among the different JAKs. And the reason for that is that they all bind to ATP. So you can imagine if they bind to the same target, they're more likely to look alike with regards to their structural homology. However, what's more unique is the left part, and that's the regulatory domain. So the regulatory domain is a bit more unique. And then our therapeutic pathway has really focused on the regulatory domain because it's more unique. So by binding to the regulatory domain, you can effectively affect fewer of these Janus kinases. And we also know, for example, in addition to TYK2 activity being elevated in patients with plaque psoriasis, what we note is that we also have natural experiments in patients who just naturally have loss of function mutation in TYK2. So this is the opposite, right? And in those patients, they're kind of these nature's experiment looking at what happens if we knock out or partially knock out TYK2 activity. So what they notice that these patients do not get psoriasis, or they have lower incidence of psoriasis. They don't get ulcerative colitis. They don't seem to get multiple sclerosis and so forth. So this inspired, I think, scientists and researchers to think about, gosh, can we partially inhibit the TYK2 pathway such that we can essentially decrease or really treat psoriasis as a result? Okay, so let's take a look at the role of TYK2 specifically in pathogenesis of psoriasis. And we touched upon some of this earlier, but let's take a look at how it kind of lays out highlighting the TYK2 in this regard. So here we have type 1 interferon binding to the receptor, and TYK2 is involved in this very early stage. So TYK2 pairing with JAK1 allows for transmission of the signals intracellularly. This then allows the cell also to secrete something like IL-23. Now, IL-23, to exert its influence, essentially, it binds to its receptor, and its intracellular signaling is transmitted through TYK2 plus JAK2 pairing, and they phosphorylate. Once they're in this particular pairing, what they do is that they phosphorylate STAT molecules, specifically STAT3, and the STAT3 molecules go into the nucleus and results in gene transcription. And the cell then will secrete IL-17. The IL-17 then work on keratinocytes, cause them to proliferate, and then you see development of plaques. So this shows that TYK2 is keenly involved in the pathogenesis of psoriasis. And really for that, it's involved early on, both in terms of the type 1 interferon signaling pathway, but also very importantly, probably more importantly, the IL-23 signaling pathway. And that's why targeting and inhibiting TYK2 is therapeutically beneficial. Okay, we have an FDA-approved therapy called deucravacitinib. It's an oral therapy. And deucravacitinib does exactly that. It inhibits TYK2. However, deucravacitinib does not inhibit the active ATP binding site that's shared in terms of structural homology with other kinases. Instead, deucravacitinib specifically binds to the more unique regulatory domain. So here you see deucravacitinib being this green triangle coming into binding the regulatory domain. And when we look at the other JAK1, 2, 3 inhibitors, for example, they tend to bind the ATP binding domain. And here we're looking at a very important slide. So here we're looking at selectivity of different medications for different targets. I will walk you through this. So I actually want to have your attention to be focused on the right-hand side of the slide where we see deucravacitinib. So this is at the doses that we use, for example, for psoriasis. So if we look at the 6 milligram QD, and what the bar represents is a percent of daily inhibition. And so what you'll notice is that you only see this light blue bar, which represents the TYK2 activity. So this shows you at 6 milligrams QD of deucravacitinib, it inhibits TYK2 activity, but you see minimal to no inhibition of the gray bar. So you don't see almost any gray bar or the dark blue bar, which represents JAK-1/3 activity or JAK-2/2 activity. So basically what we see is that at the doses we take for psoriasis, 6 milligram once a day, what you see is essentially only TYK2 activity being inhibited, and we are leaving alone any JAK-1/3 or JAK-2/2 activity. So it's very specific. If you look at the other inhibitors here, the JAK1, 2, 3 inhibitors, and for example, tofacitinib, primarily JAK1, little bit of JAK3 inhibition, upadacitinib, primarily JAK1 inhibition, and baricitinib, primarily JAK1, some JAK3 inhibition. What you will see here is that they definitely hit the JAK1 and 3s. Some of them also hit JAK-2/2 activity as well. Based on this data, this is why when we have JAK1, 2, and 3 inhibitors, we have different criteria for lab monitoring. Now, here's another look at deucravacitinib's selectivity. Here we're looking at this table, which has a few different numbers on this. This is IC50, so the inhibitory concentration. And what we see, so the smaller the number, meaning that there is much greater on-target effects. So the smaller number means that the more potent the drug is for those inhibition. So what you see is that deucravacitinib inhibits very specifically TYK2 and really inhibiting the interferon alpha, beta, very importantly, IL-23 and some IL-12 as well, whereas it leaves alone the other targets. All right, so now we're going to kind of change gear a little bit and then really think about the clinical data. How do we translate everything that we just learned with regards to the pathophysiology of psoriasis and also the TYK2 inhibition to what we see clinically with our FDA-approved medication, deucravacitinib? There were 2 global studies that were performed with deucravacitinib where patients were randomized into 3 groups, the placebo group, deucravacitinib group, as well as a apremilast group. And these 2 studies were identical up to week 24. And this, we're looking at patients with moderate to severe plaque psoriasis at baseline. And we wanted to know, how does an oral TYK2 inhibitor, deucravacitinib, do in those patients? So let's take a look. Here you'll see 2 graphs side by side. The one represent PSO1 and the other represent PSO2. Again, identically designed up to week 24. On the left-hand side, when we see the PSO1, this is pivotal study looking at primary endpoint at week 16, that the purple line, which represents deucravacitinib, is superior to the active comparator of apremilast. So at 16 weeks, nearly 60% of the patients will achieve PASI 75. And that response continued to improve. So by 6 months of time, we have almost 70% of the patients achieving PASI 75. Let's take a look at another co-primary endpoint, which is clear or almost clear. So here we have patients who were moderate to severe in terms of disease severity at baseline and looking at their response through week 24. And what you see is that at week 24, nearly 60% of the patients will be clear, almost clear. And that's about twice the efficacy of apremilast. About 31% will be at week 24. So this is very important because now we're seeing a psoriasis oral therapy with efficacy that are very similar to first-generation biologics. And also, it's at twice the efficacy of our prior advanced small molecule apremilast. And you take deucravacitinib once a day versus apremilast twice a day. We are really entering into a time where we no longer have to have the trade-off between efficacy and safety, but rather to have therapeutic options now that are efficacious and have a good safety profile. Now, I have showed you the results of deucravacitinib up to week 24. How about the long-term extension? Let's look at open-label deucravacitinib study, and now we have 4-year data for deucravacitinib. So if a patient got started on deucravacitinib and has had continuous deucravacitinib dosing in the clinical trials, now we have data following them out to 4 years in the pivotal studies from the beginning. And what we note is that about 75% of the patients will maintain PASI 75 through 4 years. So this is what I call 75 on 75, right? We have about 75% of the patients, 3/4 of the patients maintaining PASI 75 over a 4-year period of time. And this is really important that patients on a once daily oral therapy can have this level of maintenance of response. And again, this is very similar, I would say, when we look at some of the indirect comparisons to biologics, this is very similar to our earlier generation biologics. How about PASI 90? Now, PASI 90 is at least 90% improvement from baseline, which, as you can imagine, is a very high bar. And what we see with deucravacitinib is that about 50% of the patients will maintain PASI 90 through 4 years. And this is important because we want patients to be able to achieve and also maintain this high level of response over time. Now, let's take a look at the safety profile of deucravacitinib. Overall, very well tolerated by patients. And what we see here is cumulative numbers through 4 years. And when we think about deucravacitinib, overall, very well tolerated by our patients, have very low GI side effects. In fact, if you look at the number of diarrhea and nausea for deucravacitinib, it's either similar or lower than that of the placebo. So overall, patients tend to tolerate deucravacitinib very well. Now, let's talk about deucravacitinib and its effect on psoriatic arthritis. We have the phase 2 data available for deucravacitinib, which shows that it does have good efficacy on PSA. For example, 62% of the patients achieving ACR 20 by week 16 compared to 30% on the placebo group. And then currently we have phase 3 program ongoing, so hopefully we'll learn more about that in the near future. So what are some of the advantages of TYK2 inhibition for psoriasis? And currently there's only one TYK2 inhibitor approved, that's deucravacitinib. Few things. Number one, there's no box warning. There's no drug-drug interactions that are known. It's quite tolerable. It's twice as efficacious as apremilast. And also we have safety data out to 4 years showing it's a safe oral medication. And then it's a convenient pill that can be taken with or without food with once daily dosing. In terms of laboratory monitoring, you do need to check TB before starting, but overall, no lab tests are required for long-term therapy per PI insert. If you suspect the patient may have liver disease, or if the patient has a history of liver disease, you want to add some liver function enzymes at baseline, and you may want to monitor that over time. But overall, as you can see, a very good safety profile for our patients who you're considering for deucravacitinib and who have been on deucravacitinib. Because of the advantages of TYK2 inhibition, there are several molecules that specifically target TYK2 as a therapeutic target for further development in plaque psoriasis. And those include zasocitinib, for example, ESK-001. Both are in phase 3 development now for plaque psoriasis. Okay, let's go back to our patient Mark. Now, as we know, it's very important to have shared decision-making with our patient. And for me personally, I would say we definitely want to offer our expertise because we don't expect our patient to know all the numbers, to know the efficacy and safety profile, but we do want to ask them, importantly, about their preferences about shots versus pills, for example. And so here, it's important to ask them about not only their burden of disease, but, do they have any treatment goals that they want to share with us? We want to encourage and involve patients in the decision-making, because we won't be able to identify patients, for example, who are extremely afraid of needles, or patients who don't want to take pills unless we ask them those questions. And I know that we do this already on the daily basis. And I think one of the key challenges, of course, is to try to do this in the short amount of time that we have as clinicians with our patients in clinic and with the increasing burden. But I do very much ask my patients if they have a preference between pills or injections. However, I also tell them about the differences in the efficacy, in the safety, and in the frequency of these medications, so that route administration is only one component, not the entire component of our conversation and decision-making. And also, we want to ensure that we know if they have psoriasis in hidden areas, and because we want to make sure that we treat psoriasis everywhere, and especially those special areas that may be causing a lot of trouble. So I do ask patients if they have, for example, psoriasis involving the genital area, as I talk to them and later examine them. Okay, so for our patient, back to Mark, selecting a therapy. Mark was interested in exploring oral therapies. He had taken an injectable TNF inhibitor in the past, but he wanted to explore the oral therapies. And I talked to him about our various oral therapies and also the differential efficacy we have there. So Mark was started on deucravacitinib at 6 milligrams daily. And a few months later, we had Mark coming back, and I'll show you some of the photos for Mark here. And here, as we can see, the before and after photos, Mark had responded really well, as you can see, to deucravacitinib, and overall has clearance of the lesions on the arms and on the back. We also see good clearance of lesions on the back as well. And if we take a look at the leg, what we see here is also very good clearance of lesions on the legs too. So as you can see here, Mark had responded quite well to the treatment and overall is very happy about having been on this newer oral therapy. Okay, so we're going to go to our next section, which talks about how to identify patients who would most benefit from incorporating TYK2 inhibitors in their therapeutic regimen, and also how to adopt a team-based approach when we care for our patients with psoriasis. Few things, in my opinion, for patients who could benefit from TYK2 inhibitors. And again, currently we have one FDA-approved medication, deucravacitinib, that's a TYK2 inhibitor. I think overall, you can treat patients who are systemic experienced or systemic naive. They could have had biologics in the past, absolutely. I do think the very sweet spot is for people who have not had any systemic therapies, and also for those who have more moderate form of plaque psoriasis. Very importantly, I think that deucravacitinib works well for high impact areas such as scalp. So we all can imagine patients who may have diffuse scalp disease, just a few plaques here and there on the torso. So the scalp is actually 7% of our total body surface area. And if they have about 3% body surface elsewhere, also, they could qualify by a lot of payer standards for a systemic medication. So that may be a good patient, for example, for deucravacitinib therapy as well. And of course, deucravacitinib therapy is preferred for patients who design an oral therapy. Now, as we treat our patients, we also want to be cognizant that we have patients who may have limited access to transportation, to healthcare insurance, good health insurance. And I see this every day. And we want to make sure that patients from all sectors get cared for well. And therefore, it's very important to think about when we have newer therapies for our patients, how do we increase access for patients regardless of their insurance status and potentially regardless of their geographic limitations, or regardless, for example, of potentially certain cultural beliefs that they may hold for or against systemic or topical therapies. So I oftentimes look very hard for patient assistance programs. So oftentimes for these newer therapies, for commercially insured patients, there's oftentimes a pathway for these patients to access commercially for these innovative therapies. However, for patients who may have, let's say, straight Medicare or Medicaid programs, it can be a bit more difficult. That being said, many of our advanced systemic therapies, the companies will have programs based on, for example, income levels or some other parameters that allow for assistance for the patients that are not sort of insurance-based. So we do want to explore all these different angles to try to get our patients on the best treatment option for their disease. Now, let's say you're prescribed the oral therapy or the biologic therapy. What are some of the barriers to patients adhering to the therapy? Well, I think one of the key barriers can be you need to first have the patient buy-in. If you don't have the patient buy-in in the selection of the therapy, patients may go home and they say, I wasn't too keen on this therapy to begin with, and so I'm not sure about my likelihood of staying on the therapy. Therefore, what we talked about before in terms of shared decision-making is very, very important. What are some of the other factors that can influence their adherence? Do we communicate the benefits and the safety information, the side effects accurately and completely? And also making sure that when we discuss the safety profile, that we give rates on certain AEs that may be more likely to happen versus others. And where is the patient's overall literacy level? And how do we couch our conversation in ways that will resonate with our patients and appropriate for their literacy level? I see patients with a wide range of literacy level. And I oftentimes also provide them with handouts because, as we know, patients likely only remember a very, very small proportion of what we say in the office. Therefore, I always like to send them home with handouts with important information and also ways to contact the clinic if they have any questions. Close follow-up is really important right after you recommended an important medication for their plaque psoriasis. You want to maybe have them back in a few months rather than a year, as is shown by some of the adherence papers, that the frequency of follow-up really matters in terms of patients' adherence. Patients tend to use their medication the most right after they left someone's clinic and right before their very next appointment. So it's very important to understand these factors and schedule patients appropriately for follow-up. I've already touched upon some of the strategies to improve treatment adherence. I also want to emphasize, if they come with family members, to engage with the family members together. When you're in the clinic, when you're seeing the patient, they have their spouse there or their children there who are adult children. You want to make sure that everyone understands the benefit and also potential risks and how to use the medication. So I really believe, when you're in the clinic with the patient and if they have a significant other, that they give permission to be there to also make sure the whole family understands. And sometimes our patient may have cognitive disabilities that we want to make sure that their family members are also involved in terms of helping them with treatment adherence. Tell patients you're on this journey with them, and the journey can change. It can have turns, it can have U-turns even, but you're there with them. And it's important that in our shared decision-making process that we are the ones that are conveying the facts about the treatment and recommendations, but we also gather patients' value and preferences. And this is very important to making sure patients are adherent. And studies have shown that shared decision-making does improve patient satisfaction as well as their adherence. Now, let's get back to Mark. You recall that Mark was a 42-year-old man who was initiated on oral therapy, a TYK2 inhibitor for his plaque psoriasis, and Mark did well in that. But now let's go beyond Mark. Let's think about what if you have a patient similar to Mark, but instead of 42 years old, 68 years old. How would your considerations change? Here, I would say when we think about patients who are older, they tend to have polypharmacy. They tend to have a lot of different medications. And therefore, considering medications that will not interfere with their other medications are very important. Drugs that don't have drug-drug interactions. And also, how does the frequency of having to take the medications, how does that take into account in terms of thinking about elderly patients? Some elderly patients may prefer take oral therapies. Other elderly patients don't want to deal with, for example, injection preparation or the physical active injection and so forth. So things really need to be taken into account. But in the elderly, mostly consideration of how does my psoriasis therapy affect their comorbidities, and also what are the possible drug-drug interactions. All right, what about if Mark has never tried a biologic, right? In the base case, we had Mark had tried TNF inhibitors. What if Mark never tried biologic? So this actually will probably consider almost a more ideal scenario in the patient, which I talked about before, is that if they've never tried a systemic therapy or never tried a biologic therapy, this is our opportunity to intervene and make sure that they get on the appropriate therapy, including, for example, possibly considering a TYK2 inhibitor and get them to a path where they can have their psoriasis better controlled. So with that, I want to conclude by highlighting some of the key elements of the presentation. Number one is that when we think about psoriasis pathogenesis, IL-23 is a master regulatory cytokine that's very important for the Th17 cell sustainability as well as expansion. And we now have oral therapies that target the intracellular pathway of IL-23. And by doing so, it can dampen the Th17 response and dampen the downstream production of IL-17, which are critical to psoriasis plaques and psoriasis pathogenesis. And when we look at the TYK2 inhibition, the focus now is on inhibiting the more unique regulatory domain as opposed to the more commonly shared active domain of the molecule. We have deucravacitinib, which is currently the only FDA-approved TYK2 inhibitor for patients with moderate to severe plaque psoriasis. And it has efficacy that are very similar to our first-generation biologics. And what we are seeing is that 4-year efficacy of 75% of patients achieving PASI 75 and about half the patients achieving PASI 90. Overall, very well tolerated. A small proportion of patients may have some acne when they start, about 2%, but overall manageable. It does not necessitate discontinuation of the medication. And then finally, we want to ensure as we approach our patients, regardless of the therapy that we recommend, it needs to be individualized. We need to be aware of the health access barriers, health disparities that may be present with different patient populations, and ensure that we work hard with our patients through shared decision-making and also work with our community of healthcare providers in terms of addressing other comorbidities that our patients with psoriasis may have. With that, I want to thank you so much for your attention, and I hope you have learned a lot, and I hope to see you next time. Take care. Bye-bye.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/RJG860.